gluteal muscles we have to discuss, and other structures were present over here we have to discuss. Gluteal muscles, we know we have three gluteal muscles named as a gluteal according to their size: maximus, medius and minimus. And then when we go deep to them, अगर हम उसको लिफ्ट अप करेंगे इनको, तो अंदर भी हमें छोटी छोटी मसल्स. I told you, whenever you talk about the action of a muscle over the joint, मसल का काम क्या है? एक्शन, मूवमेंट. कहाँ पर? जॉइंट में. अब वो जॉइंट में तो आप ये you keep in mind that what is the attachment of a muscle, and don't go in detail, medial two-third, lateral one-third, no. You should have an idea of that. Just like we previously discussed about the sartorius. The sartorius जो है वो anterior superior spine से लेके निकलती है, तो हम lower down और medial की तरफ जा रही है. उसका डायरेक्शन, सिर्फ डायरेक्शन देखिए, and it is going towards the knee joint. It is going on the medial side. अब जब इसको आप कंसीडर करेंगे कि if it is related to the hip joint laterally, एक तो हिप जॉइंट भी वर्टिकली क्रॉस कर रही है, तो अगर ये कॉन्टैक्ट करेगी तो फ्लेक्शन, देयर इज ए फ्लेक्शन. इट इज क्रॉसिंग द नी जॉइंट पोस्टीरियरली, वर्टिकली अगेन, पोस्टीरियर पे नी जॉइंट पे वर्टिकली अगर कोई मसल जाएगी तो अगेन द फ्लेक्शन एट द नी जॉइंट. ऑन द हिप जॉइंट दिस मसल इज रिलेटेड टू द लेटरल साइड. So if it is related to the lateral side means it causes lateral rotation at the hip joint, and at the knee joint it is related on the medial side, so it is causing medial rotation at the. Just see attachment muscle, its direction of fibers and its relation with the joint. You don't need to read actions of muscle from the book. You don't need. You just understand yourself. So here in the gluteal region we see here, we start from here, you see from superficially we will go. Skin is very much important here. Skin is very much important here because that this gluteal region is important from clinical point of view. It is important from clinical point of view because we have huge muscle of the body present over here in this, and that is the gluteus maximus. And it is clinically used for intramuscular injections.
Yes.
For intramuscular injections, you have to select huge, bulkiest muscles. Like we have the gluteus maximus over here in the upper
deltoid.
The deltoid. In the front of the thigh, we have the vastri, especially the vastus lateralis. देखा है आप लोगों ने? You have seen this के vaccination बच्चों को करते हैं तो they put over here thigh. ठीक है? Vastus lateralis, medialis. And vastus, especially vastus lateralis, it is bulky. Okay, so we need bulky muscle for the intramuscular injection. So we have this, but see here that when you are injecting over here in the gluteal region, आपको करना क्या है कि you have to be careful about inserting the needle because there are nerves, they are present all over the area. So you have to select the area where there is a minimum nerves they are present over here. Okay, so minimum number of nerves are present over. So mostly clinically this gluteal region, you see that this is the highest, this is the iliac crest. It shows like this. This is the iliac crest. Superior limitation. Gluteal region is the iliac crest, upper border. Okay, and then iliac crest are the superior border of the ilium. Okay, and lower down we have this fold.
Gluteal fold. Defines.
Some books say that it represents the lower border of the gluteus maximus, and some say it is not. Actually, the fibers of gluteus maximus, I told you, they are not horizontal, not vertical, they are oblique. And this gluteal fold you see here. ये नजर आ रहा है आपको? ये वाला ऐसे. This gluteal fold is horizontal, almost horizontal, and maximus lies like this. So this actually doesn't represent the lower border of the gluteus maximus. Okay, this gluteal fold is actually the line of demarcation between the gluteal region and the thigh. Okay, on the posterior spine. So you see, and medially we have the natal cleft. Between two buttocks we have this region. This is the natal cleft. So these are the margins of. Okay, so then see here, the superficial fascia. It is thick. It has to be thick. Because this area we use for sitting purpose. We need here bulk, we need here fat for cushion, So the skin itself, the superficial fascia itself is thick. Then we have a lot of fat present over here. And then we have the bulkiest muscle of the body, gluteus maximus, lying over here. So when you sit over a hard area, this is soft, but when you sit over a hard area, it feels like a cushion we have here. Otherwise, whenever we sit for a certain time, then if the touching of the bone, you see bone is covered by the periosteum, it's pain sensitive. Immediately we feel pain. Okay, so अब देखिए यहाँ पर आप ये thick, dense and well developed ligament with large quantities of fat, especially in the women. It gives the characteristics convexity to the buttock. Okay, so it forms thick cushion. We need a cushion over here. And we have a part of a bone here, that is the ischial tuberosity. I told you, this is the sitting bone. Ischial tuberosity is sitting bone. Okay? And this is the cutaneous nerve supply. For the cutaneous nerve supply, this gluteal region is divided into 4 parts, 4 quadrants. So you can say 2 upper, 2 lower, upper outer,
Medium.
upper inner,
Yes.
lower outer, lower inner. So these are the nerves they are supplying. Upper lateral, this one is upper outer quadrant. It is supplied by some branches of the L1 nerve. Now we are here in this region L1. We have iliohypogastric nerve lying over here. Its branches. It is some branches. And then upper medial is posterior rami of L1, 2, 3, even the S1, 2, 3. Upper medial. Upper medial, this one. Posterior rami of L1, 2, 3. But upper outer quadrant में हमारे पास सिर्फ iliohypogastric की some branches. Okay. Then lower lateral quadrant, it is branched from the lateral cutaneous nerve of the thigh. You see lateral cutaneous nerve of the thigh, when it arises from the femoral nerve, it divides into 2 branches, anterior, posterior. Posterior will go posteriorly, anterior will go anteriorly. So your anterior, lateral and posterior aspect is supplied by the lateral cutaneous nerve of the thigh. Okay? And then you see here the lower medial quadrant, branches from the posterior cutaneous nerve of the thigh, S1, 2, 3. Okay, floor of the lateral cleft is sacral and coccygeal nerves it is supplying. So minimum number of nerves is present in the upper outer quadrant, where branches of the iliohypogastric nerves they are. This is clinically important. Whenever you are inserting needle for intramuscular injection, you have to insert an upper outer quadrant. Mind it. जब भी अब आपको इंजेक्शन लगानी पड़े ना, वो उसको ऐसे जो है वो डिवाइड करते हैं इसके इस तरह से कि ये देखें यहाँ से बिल्कुल in the middle and from this upper portion of the lateral cleft you go laterally cross हो गया. So you have 4 quadrants, upper outer, upper inner, lower outer, lower inner. So this upper outer having the minimum number of nerves over here. Clinically इसको use करते हैं, ठीक है. So then we see here the arteries. We will discuss later on. So we have here muscles over here. We have the muscles over here. See here deep fascia. Another very important thing is that the continuation of the fascia lata is split to enclose the gluteus maximus at its lower border of gluteus maximus. जब हम पढ़ेंगे ना, gluteus maximus when it takes origin from the ilium bone, you know.
Yes, sir.
Posterior to posterior gluteal line.
Yes, sir.
Okay. Then it goes and it is also taking origin from the sacrotuberous ligament, and it is also taking origin from some part of the sacrum. Then it is going laterally. Laterally it has to be inserted over the femur. अगर आपको याद हो तो हमने देखा linea aspera, when it goes up it diverges, when it goes down it diverges. Downward divergence is the supracondylar ridges, medial and lateral supracondylar ridges. Upward divergence, medially it is continuous with the intertrochanteric line below the lesser trochanter. Lateral divergence. Lateral divergence go upward, just lateral to this lateral divergence. You see here. You see here, this is linea aspera. It goes medially, suppose this is right side, it is going medially. We have a lesser trochanter. It goes anteriorly to be continuous with the intertrochanteric line. It goes laterally here, over here, lower down into the supracanal ridges. So, just lateral to this lateral divergence, we have a tuberosity. Should it be on the lateral side or medial side? Tuberosity. Medial side. Am I right or wrong?
Medial side.
Medial side, yes. Now consider it. This most posterior muscle of the medial compartment is the most posterior muscle of the medial compartment is the adductor magnus. Adductor magnus. Adductor magnus is attached to the whole of the linea aspera, middle of the linea aspera. Lower down it is going to the medial supracanal ridge. Upward it is going this lateral aspect. Now see, this is the muscle of the medial compartment, adductor compartment. Now, gluteus maximus is muscle of posterior compartment. Now, just using your common sense, you see that this is the muscle of the medial compartment, and this is the muscle of the posterior compartment, which should be on the medial side. एक मीडियल कंपार्टमेंट की मसल है, एक पोस्टीरियर कंपार्टमेंट की मसल है. मीडियली कौन सी होनी चाहिए? इसमें सोचने की जरूरत नहीं है.
मीडियल वाली.
जिसका नाम ही मीडियल है, इट शुड बी ऑन द मीडियल साइड. पोस्टीरियर कंपार्टमेंट की मसल उसके लेटरल होने चाहिए. Your gluteal tuberosity is lateral to this lateral divergence of linea aspera. So gluteus maximus muscle taking origin from here goes. It is inserted over here, taking origin from the ilium, sacrotuberous ligament, whatever, inserted over here. But little portion of the gluteus maximus is inserted over here. These fibers are vertical. Somehow they are vertical. If they are vertical, we say vertically it is going downward, means that it is the extensor of the hip. Vertical relation leads to extension. Other 75%, these are 25% fibers. At 75% fibers, they are going laterally to be incorporated in the deep fascia. And we have a specialty of the deep fascia on the lateral aspect. A fibrous band
Iliotibial tract.
extending from the ilium to the tibia. Named as
Lateral
iliotibial
condyle.
tract. It is incorporated in this. इसका पर्पस क्या है? What is the purpose? कि ये क्यों incorporated है इसमें? ये incorporated इस वजह से, एक तो ये oblique fibers जा रहे हैं, they are the lateral rotators. ये incorporated इस वजह से it has to strengthen actually the deep fascia. And then iliotibial tract, your iliotibial tract crossing the knee joint anteriorly. Knee joint पे anterior पे क्या होता है? Extension होती है. This is a tract. This is not a muscle. ये करता कुछ नहीं है, but it maintains the extended position of the knee joint. आपका knee joint extend है, उसको ऐसे टाइट करके खींच के रखा. टाइट किया, आपका knee joint flex नहीं होगा, जब तक ये muscle relax ना हुआ. Okay, so this is actually, see here that above the gluteus vertebrae it is continuous as one layer, and here it covers gluteus medius and gets attached to the iliac crest. This is actually the attachment of the deep fascia. So see here. Now what happens then? Gluteus maximus taking origin from the ilium and sacrotuberous and sacrum goes to be inserted 25% over the gluteal tuberosity, 75% in the iliotibial tract.
Yes.
When we lift, and this, you see here that this gluteus maximus, it is extensor. It is fibers are vertical as well as oblique. It is extensor and it is lateral rotator. It is extensor, but it is chief extensor.
Chief extensor, yes.
I am walking on this surface. Do I need force for this? No. But if I am going up the stairs,
No.
I am going against the gravity, I need a force for this. And this force here It is provided by the gluteus maximus. Then if I am walking on a smooth surface, plain surface, I don't need force, but I am extending my hip joint. From where it comes? Which muscles are incorporated in this action? These are the muscles of the posterior compartment of the thigh. Especially we named as muscles of the posterior compartment of the thigh.
Hamstrings.
Named as, yes, hamstrings muscles. Hamstring muscle. Hamstring muscle, the difference between these hamstring muscles, they are normal extensors. Just you are walking on the smooth surface. But whenever you are going up the stairs, you need a force here, anti-gravity. And this is provided by the gluteus maximus. Because of that, this is called as the chief muscle. Chief anti-gravity muscle, chief extensor of the hip joint. Another thing is that, एक और आपको आइडिया देता हूँ, you just keep in mind. I am standing over here. I am standing over here. Now I am sitting. Do I need support of the gluteus maximus?
During sitting?
No. I am just sitting. I am going towards the gravity. No, I need support. Yes.
To control that movement.
Yes, because अगर मैं I am sitting, gravity is pulling me downward.
Yes.
If this muscle, suppose it is not here, I will suddenly fall.
Paradoxal.
This, yes, paradoxical action. Now what happens that this muscle actually, whenever I am going to try to sit here over here, this is anti-gravity muscle, this slowly relax. Slowly, and you are smoothly and slowly you are sitting. Again, this is acting, again it's the gravity. Gravity is pulling downward, but this is anti-gravity muscle. It is now relaxing. It is active during extension. Now it is relaxing, but it is relaxing slowly to prevent you sudden fall. Okay, so this is the muscle, and then we lift up this muscle. We have other two gluteal muscles, which are arising from the gluteal surface of the ilium.
Yes.
Don't need from this is okay. They both are arising from the gluteal surface. You should have an idea of that.
Yes.
And then they are attached over. It is now see the pattern. These muscles, gluteus, two muscles. Now medius and minimus. These muscles, they cross the hip joint laterally and anteriorly. So they are going laterally, not proper anteriorly, laterally, then coming little bit anteriorly. They are attached over the greater trochanter of the femur on the lateral aspect, laterally crossing. तो अगर lateral cross कर रहा है तो क्या होगा? कि वो lateral aspect में, and then going anteriorly to the anterior surface of this. Okay, so they are attached over here. What they do actually?
Lateral rotation and abduction.
They are crossing over here, on the lateral aspect. What they do actually? They contract and they cause this action.
Abduction.
Keeping the leg away from the body.
Abduction.
They are major abductors of this. And then they are going little bit anterior towards the anterior surface of the greater trochanter. Whenever they contract,
laterally rotate.
no, actually they are going like this.
Medial.
So from here, your gluteus minimus is more anterior. From here, it is going towards the lateral. See here, this is the direction. Whenever it contracts.
Medial rotator.
Yes, it's called a medial rotation.
Okay.
One thing is that they are the true abductors. They are true abductors. This is the action, but they are helping you in your gait. What is gait? If anybody asks you what is gait, you just say it is the pattern of walking.
Yeah, gait.
You are just walking.
Yes.
The pattern of walking is gait.
Gait.
It might be normal. What we are doing, we are walking normally. It might be abnormal.
Muscles weakness.
These are two muscles they are helping in this. These are two muscles they are helping over here. How? You see, not only this that they are causing the abduction. But you see, obviously during the walking, your one foot is on the ground, another is off the ground. Okay? Another is off the ground, it means that foot which is off the ground, it has tendency to fall downwards because of the gravity. But the balance should be kept over here. Now what happens that I told you the primary and the secondary action of the muscle. बताया था मैंने आपको, शायद फिर उसको रिपीट करते हैं. Primary action, a muscle might cross one joint, 2, 3, 4. The primary action of the muscle will be on that joint which is lastly crossed by that muscle. जो आखिरी जॉइंट उसको क्रॉस करेगा ना, उस पे जो है उसका वो प्राइमरी एक्शन होगा. Towards the primary action is towards the insertion side. This muscle is causing abduction, moving the insertion. So primary action of the medius and minimus is the abduction. Secondary action is towards the origin. Now whenever you are walking, your one foot is on the ground. Suppose your right foot is on the ground, your left foot is off the ground, and your left side has tendency to fall downwards because of the gravity. What happens that now these right muscle, now your actually insertion is fixed, femur is fixed, insertion fixed. Your pelvis will tilt, has the tendency to tilt on the left side, unsupported side. This is supported side. What happens that this origin, actually this medius and minimus, they contract. Contract means that insertion is fixed. Origin, it keeps this right side in its position. Because pelvis is one entity, anteriorly pubic symphysis, posteriorly sacroiliac joint, whole pelvis. If it is moving, whole pelvis is moving. अब क्या होगा कि ये देखिए, हमने इसको उठाया, ये unsupported side है. It has tendency to fall downwards. On the right side, left has tendency to fall downwards. It is unsupported side. Right is supported. On the insertion is fixed. Origin contracts, and what happens that if it has tendency, it will not, because of this contraction, this actually keeps the right side in its balance. So the left side would be in balance. अलग नहीं है, left side is not separate. अलग नहीं है, उसके साथ है. ठीक है, तो ये उसको maintain करती है. And then again, when this side is supported, this is unsupported, it has tendency to fall back downward. Then left muscles, means you can say that they are actually supporting the opposite side for tilting during the walking. This is normal gait, and this is normal gait is supported by the gluteus medius and minimus. But if they are paralyzed, so this is then abnormal gait. If they are paralyzed, you see, you just keep this up during walking. Suppose right are paralyzed, right muscles are paralyzed. Okay, you are walking now. This is supported, right side is supported. Nothing will happen on right side. Muscles are right, but they have actually support opposite side. जो right वाली है उसको left को support करना है, जो left वाली है उसको right को support करना है. ठीक है, अब ये right side का मैंने पाँव रखा यहाँ पर. Right muscles are paralyzed. What happens that left side will tilt downwards. It has tendency. Right muscles already paralyzed. They can't do anything, and it will go downwards. मगर उस पेशेंट को आप देखेंगे ना, वो पता क्या करेगा? वो इस तरफ गिरेगा ना. हम करते हैं ना वो लॉ ऑफ इनर्शिया, आपने सुना है कि आगे गिरने की कोशिश करते हैं तो पीछे होने की कोशिश करते हैं. तो वो इस तरफ उसको टेंडेंसी, राइट पैरालाइज है तो लेफ्ट गिरेगा, या लेफ्ट पैरालाइज है तो राइट गिरेगा. वो करेगा क्या? अगर राइट उसकी पैरालाइज है एंड लेफ्ट पे साइड पे वो गिरेगा, वो क्या करेगा? उसको करने के लिए, बैलेंस करने के लिए वो इस तरफ गिरेगा. पेशेंट को अगर आप आगे आप क्लिनिकल साइड पे जाएंगे तो ये आपके काम की चीज़ है कि वो बंदा फिर वो कंपनसेट करेगा एक्चुअली. अदरवाइज उसकी गिरेगी लेफ्ट साइड नॉर्मली, क्योंकि राइट इज सपोर्टिंग लेफ्ट साइड, लेफ्ट मसल्स आर सपोर्टिंग राइट साइड. This is abnormal gait, or this abnormal gait, other if it is unilateral on one side, this is called as the lurching gait. This is lurching gait. ठीक है? This is gait. normal walking pattern.
GIT.
It is unilateral. ठीक है, ये आपका unilateral. If it is bilateral, then it is called as waddling gait.
पेंगुइन गेट भी बोल सकते.
भूल के भी इसको वेडिंग गेट नहीं कहिए,
पेंगुइन नहीं, डबल.
भूल के भी वेडिंग गेट, क्योंकि वेडिंग गेट में सारे गेट एब्नॉर्मल हो जाते हैं. वेडिंग के बाद सारे गेट जो है ना वो एब्नॉर्मल हो जाते हैं. इसमें सिर्फ दो तरफ का होता है, उसमें सारे तरफ के होते हैं. सो इफ इट इज यूनिलेटरल, अगर एक साइड के मसल पैरालाइज है, दिस इज लर्चिंग. अगर दोनों साइड के मसल पैरालाइज है तो वेडलिंग गेट. ओके, सो दिस इज एक्चुअली ग्लूटल मसल्स. ये तीनों ग्लूटस जो इंपॉर्टेंट ग्लूटल मसल्स है, वन इज दैट ग्लूटस मैक्सिमस, चीफ एक्सटेंसर, एंटी ग्रेविटी मसल. Just keep in mind, extending from ilium and the sacrotuberous ligament towards the gluteal tuberosity, 25%, 75% in the iliotibial tract. So what? अब देखिए, मैं आपको ये कहता हूँ आइडिया बना है ना. अब कोई एक्शन आपसे पूछता है, रट्टा लगा दे ऐसे ऐसे, नहीं. आप देखिए यहाँ से गई और इस तरफ गई, 25% आपके जो है वो ग्लूटल ट्यूबरोसिटी पे है और 75% इलियोटिबियल ट्रैक्ट में है. अब सिर्फ सोचें, पोस्टीरियर एस्पेक्ट ऑफ द हिप जॉइंट का पोस्टीरियर एस्पेक्ट पे है, वर्टिकली ऑब्लिकली जा रही है, मतलब दोनों एक्शन होंगे. दोनों एक्शन कौन से? वर्टिकल वाला एक्शन एक्सटेंशन, हॉरिजॉन्टल वाला एक्शन लेटरल रोटेशन. बोथ एक्शन आर असाइन्ड टू दिस. सो इट इज एक्सटेंसर but chief extensor, and it is lateral rotator, and it is supports the body by extending the knee, by keeping the extension of the knee joint through iliotibial tract. उसको खींचेगी, iliotibial tract खींच जाएगा, आपका जो नी है एक्सटेंड पोजीशन में है, आपको कोई वो नहीं है, आपकी सपोर्ट है, बस वो गिरने नहीं देगा, उसको फ्लेक्स होने नहीं देगा जब तक आप खुद ना चाहें. ठीक है, तो these are actually actions of this. हम इन तीनों मसल्स को लिफ्ट अप करते हैं. तो फिर हम जाते हैं अंदर जाते हैं तो हमें छोटी मसल्स मिलती हैं. वो छोटी मसल्स जो है वो इन्हीं हिप बोन से कहीं ना कहीं पोर्शन से निकलती है, गोइंग स्ट्रेटली, मीन्स के वो ट्रांसवर्सली टुवर्ड्स द फीमर. डिटेल छोटी मसल शॉर्ट लेटर, ये शॉर्ट मसल्स जो है इनकी डिटेल आपसे ज़्यादा कोई नहीं पूछेगा. गोइंग लेटरली टू बी इंसर्टेड ओवर समवेयर. हिप जॉइंट को हॉरिजॉन्टली क्रॉस कर रही है, फ्रॉम हिप बोन टू द फीमर. हिप जॉइंट को हॉरिजॉन्टली अगर इन्होंने कांटेक्ट किया तो ये ऐसे मूव कराएंगे फीमर को, ऐसे लेटरल रोटेशन. इसीलिए दिस होल ग्रुप इज कॉल्ड एज शॉर्ट लेटरल रोटेटर. दिस होल ग्रुप जिसमें हमारे पास पैरिफॉर्मिस है, गैमेलस सुपीरियर है, गैमेलस इंफीरियर है, क्वाड्रिटस फीमोरस है. नाम भी याद आ जाए तो इट्स ओके, नहीं तो इतनी छोटी मसल्स आई डोंट थिंक सो कि ज़्यादा इतने डिटेल में कोई जाएगा. बट यू शुड हैव एन आइडिया कि इनका काम क्या है.
ऑब्स्ट्रेटरी
लेटरल, दे आर शॉर्ट लेटरल रोटेटर, दे आर नेम्ड एज शॉर्ट लेटरल रोटेटर. अब जो आपके ये दो तीनों ग्लूटल मसल्स हैं, इन तीनों ग्लूटल मसल्स की जो है वो नर्व सप्लाई, जो मेन ग्लूटल मसल्स है, ये आपसे पूछ सकते. दिस इज वेरी मच इंपॉर्टेंट. व्हेन यू गो फ्रॉम बैक, मोस्ट सुपरफिशियल इज द ग्लूटस मैक्सिमस. लिफ्ट दिस, देन यू विल स्ट्राइक ग्लूटस मीडियस. लिफ्ट दिस, देन यू विल स्ट्राइक द ग्लूटस मिनिमस. Then nerve supply, because this gluteus maximus is actually not only posterior, it is even going downward inferiorly. ये आइडिया ध्यान में रखें. Even going inferiorly as well. Medius minimus नहीं, सिर्फ ये. There are two gluteal nerves. One is inferior and another is superior. ये मसल बड़ी भी है और सुपरफिशियल भी है और नीचे भी जा रही है. it is supplied by, because it is going inferiorly, so it is supplied by the
inferior.
inferior gluteal
Gluteal
nerve,
nerve.
gluteus maximus. Otherwise, those two they are supplied by superior gluteal nerve. This is frequently asked, इसलिए बता रहा हूँ कि nerve supply इन तीनों muscles. 2 मिनट का ब्रेक, इसके बाद फिर